we'll move on to our last presentation. Kevin Rogacki from Northwestern is going to talk about in-training exams.
Yes, thank you for having me today. Thank you for sticking around to the last presentation here. My name is Kevin. I'm from Northwestern. I'm going to be talking about an analysis of the radiation oncology in-training exam, also known as the TXIT, and its content using a care path conceptual framework. I have also many wonderful collaborators at UChicago, Northwestern, and Mayo Clinic who helped with this work. So a little bit of background. We're all familiar with the in-training exam. It's an annual exam given to radiation oncology trainees. Currently, it's 300 questions taken in a proctored environment over 4 hours. It's been administered by the ACR for over 30 years, and it's used to benchmark trainees and programs across the U.S. with each other. And it's often used as a formative exam throughout the 4 years of training to assess preparedness for the ABR licensing exam, specifically the clinical radiation oncology and radiation physics and radiation and cancer biology exams. The radiation oncology care path is another concept that we're all familiar with. It represents the discrete steps involved in treating patients with radiation. For instance, everything from the initial consultation, taking a history and physical, to performing a simulation, contouring, treatment planning, and then treatment, follow-up, and toxicity and its management. And to an extent, this also represents the patient experience as they move through radiation treatment. And the radiation oncology care path is useful to model radiation oncology medical education because if you can demonstrate competency in all these steps, it is, the assumption is that you are competent for independent practice. So with those two things in mind, we wanted to longitudinally assess the content of the in-training exam through this conceptual framework. We hypothesized that some aspects of this care path would be overrepresented on the examination, while others would be underrepresented. To do this, we took this care path and we focused in on the center square, and we translated this into what we're calling primary care path domains. So we settled on 11 primary care path domains, topics and categories such as diagnosis, treatment planning, toxicity and management, medical knowledge and treatment decision is one, as well as other topics like radiation biology, radiation physics, other things we're familiar with. Some of these topics are pretty broad, so we decided on creating some subcategories for these primary care path domains. So there are some secondary subcategories, which we're calling secondary care path domains. For instance, under treatment planning, you can see there's simulation, contouring, dosimetry, and dose constraints. We had 2 coders take the examinations from 2016 and 2019, representing about 1,200 questions in total. And each coder independently categorized each question by the primary care path domain, and then if applicable, the secondary care path domain. If they agreed, we called the question categorized. If they disagreed, then we asked a third coder to step in and provide an assessment. If they agreed with any of the initial 2 categorizations, then the question was categorized. There's no consensus reached, we call the question uncategorized. Here's an example of a question from 2016. It's asking about the appropriate interval for follow-up skeletal surveys for patients treated with a solitary plasmacytoma, the answer being 9 to 12 months, and the question being derived and the answer being derived from NCCN guidelines. In this case, both the initial 2 coders agreed that the primary care path domain would be medical knowledge and treatment decision, and its subcategory or secondary care path domain is management. In terms of looking at all the questions, there was good agreement between the initial 2 coders. So both in the primary care path and secondary care path domains, there was good to excellent agreement according to the Kappa coefficient. About a third of questions, however, there was some sort of disagreement with either categorization. So a third coder was asked to assess those questions, and in most cases, the questions were then categorized, but in about 7.8% of questions, 94 questions total, we ultimately called them uncategorized. In terms of breakdown by the categories of questions, our hypothesis was correct. There was an imbalance in the test. So by far and away, the most prevalent question had to do with those relating to medical knowledge and treatment decisions, followed by diagnosis-related questions, followed by radiation biology, radiation physics, and then treatment planning. And then down the line, you can see toxicity and management is fairly underrepresented, representing only 45 questions. This is another way to look at that information. You can see that over 50% of the exam questions are dedicated to questions relating towards diagnosis and treatment decision and medical knowledge. On the top left corner, only about 15% of questions are dedicated to treatment planning and toxicity management. And this breakdown doesn't necessarily reflect the time spent on these steps in the clinical care path when you're practicing in the clinic. When looking at the subcategories of the two most common primary care path domains, we can see under the medical knowledge and treatment decision, the most common type of question was derived from randomized control data. So 43% of questions were generated from those types of studies. And in terms of diagnosis, secondary care path domains, you can see that most questions were asking about staging, or what we're calling oncoanatomy, which concern patterns of spread, or questions relating to what would happen if a tumor presented in this area of the body. In terms of the most or the least represented care path domains, under treatment planning, we can see the secondary categorizations had to do most with contouring, dose constraints, and dosimetry, while simulation was relatively infrequently asked. And then under toxicity and management, we can see most questions had to do with late toxicity evaluation and management, and relatively few acute management questions or acute toxicity questions. So in conclusion, the in-training examination questions are imbalanced when analyzed by this clinical care path framework. It tends to favor questions relating or asking about medical knowledge, treatment decisions, as opposed to other topics like treatment planning, such as contouring, plan evaluation, or recognition of toxicity and its management. Therefore, it's hard to say that the in-training exam could be used to assess the global competency of a trainee, especially in terms of clinical skills. And it's also a little bit worrisome if the ABR, radiation oncology examination, reflects the content of the in-training exam, then the ABR licensure process could be under-assessing some critical clinical skills. However, to play devil's advocate, the in-training exam is a useful tool. I think it accomplishes its goal of broadly testing knowledge, and it may not set out to test every clinical skill equally. It may rely on the assumption that other forms of medical education may be better suited to evaluate competency in certain areas. For instance, there's a lot to be said for the knowledge gained through clinical rotations and evaluating toxicity and its management. It's also sometimes difficult to write questions that are where the answers are more subjective in nature, where there may be more than one correct answer and one correct approach, such as in treatment planning. It's much easier to write a question about a randomized control trial and the results of that trial. However, I think we'd argue that it's advantageous to formalize assessment of all of these critical clinical skills and put in practice. This will help avoid any blind spots in the field and among independently practicing radiation oncologists as they graduate from programs. And with that, I'm happy to take any questions. Thank you for listening.